Press record. Okay, we're all set up.
So you guys are all from Israel?
Yes, we are.
Awesome. One of my favorite countries.
Well, when are you gonna come? I spoke to Hila Weiss. I heard we trying to organize something eventually.
Oh, I would love to go there.
We would love to have you. It's a great country.
So you can hear me well, right?
Yeah, yes, yeah.
Okay. So I'm going to talk to you about Ehlers-Danlos syndromes, and I know some of it may not be relevant, but one of the things about whichever profession you're in medicine is to understand the disease, understand the condition, and besides knowing what to do, it's also important to know what not to do. And so we'll talk about that, and also about recognizing what are the issues that patients have. Like for example, you may have a patient, I believe you're all physical therapists, right?
Yes.
So you may have a patient who will come into your office and you may notice something. Actually, over here, a lot of the physical therapists are the ones who recognize hypermobility first. And they then let the doctors know, and then they move forward from it. So because you're working very closely for a while with the patients hand to hand, and so you recognize things that physicians don't. Now, say a patient with hypermobility comes to you and has, let's say, has headaches, and the patient never mentioned it to the doctor, or did mention it to the doctor, but you realize that this is a serious issue or a red flag. That's what I'm going to do today, is to help you recognize these things so that you can then help the patient forward and put them in the right direction. So it's called connecting the dots, because Ehlers-Danlos syndrome is not as simple as we think it is. It's not simply joint hypermobility. It's way more than that. And how do you connect all these things? We don't need to realize that. We need to recognize that patients, we are a whole person. We are not an arm. We are not a right arm. We are not a left arm. We are not a right leg. You may have a patient that may come in with back pain, but you have to recognize other issues these patients might have, and they may need help with that, and you'll see all that. So just as a disclosure, I'm the director of the Center for Complex Conditions here at the Brown Medical School in Rhode Island. I did my training at the Harvard Medical School. I'm on a bunch of nonprofit organizations, and I don't have any financial disclosure. So I'll be talking about products or something like that. I don't have any financial interest in them. This is a presentation. This is generally this slide is not just you, it'll probably be seen by patients also. So I just want to talk to you about that. This is only for information purposes, not for treatment purposes. And there might be some off-label uses of medications. So the important thing to remember about EDS is that the three things to remember. One is that they have weak connective tissue. So my tissue is tough. In EDS, the tissue is softer, which means that it breaks down easily. And not only that, it also takes much longer to heal. And this is a really, really important concept to understand. If there's one thing that you're going to take from this presentation, is remember this. They break down the tissue much easier, and they also take much longer to heal. They have poor joint position sense of proprioception. I'll talk about that. They also come with coexisting medical conditions like dysautonomia, mast cell activation syndrome, headaches, spine problems, all kinds of problems. In fact, we're starting to discover more and more of those. So how do you manage pain? It's a misconception that when people always ask me, like, what do you do for pain? That's kind of doesn't make sense at all. You can have pain from somebody who stuck a knife in your back, or you can have pain from a headache. So the management is going to be completely different. Management of gallbladder pain is going to be very different from um, management of an appendectomy. So, so to understand, to treat pain, you have to know the cause of the pain. You have to know what's broken over here. So for example, I'll give you an example. If somebody comes in with a dislocated shoulder joint, the pain can be from the dislocated shoulder itself, or it could be the muscle spasms of the rotator cuff group around that. Remember, when the shoulder comes out of its place, the muscles around it go into a spasm. It can also happen from impingement of or damage to a nerve or blood vessel in that area, like in thoracic outlet syndrome, or it can be all of the above. So it's really important to understand who's the culprit here. And it may not be one culprit, it could be many culprits. So the treatment for each of these is different. The same thing applies to treatment. There's no one specific treatment. You can't say, okay, hey, the treatment for your pain is this. There's no such thing. So you use what is called the 10% rule, and I call it the NC10. NC10 rule means that if you can get 10% from one thing, 10 from another, 10 from another, 10 from another, and if you have 10%, that's 50%. And that's what we are looking for. That's what patients are looking for. No one is looking for 100%. That's a dream, but we're looking for 50%. But most importantly, we're looking for function. So for example, somebody may come to you with knee instability. So how do you help this patient? You could get some relief with stabilizing the knee with braces. You could start with strengthening the muscles around the knee. And some you can use medications that come in different types you can use. So you get 10% from each, you get 10%, and that's 50%, which I call the NC10 rule. So I'm going to start from head to toe. That way we cover everything. Headaches are extremely common in EDS. These are 9 conditions that I've listed, but there are much more than that. But I just picked up the 9 important ones. Migraines are common in EDS. Now, migraines are common in women also, and most people that you're going to see with EDS symptoms are actually women. Now, EDS presents equally in men and women, but it causes problems more in women than in men. So migraines is one of them. Now, a migraine doesn't mean any bad headache. So oftentimes I'll have patients, they'll say, oh, I have migraines, but the criteria for migraine is very specific. It's one-sided, it's intense, it's throbbing, it's like somebody putting a knife in your eye, and it's associated with photophobia. That means they can't tolerate bright lights, they can't tolerate sounds. So it has to meet all of these criteria. Chiari malformation, I'll explain this to you in a minute. Cervicogenic headaches, you're all familiar with that. That's the muscles that go to your, from your neck to your head. Temporomandibular joint dysfunction. This is another very extremely common cause of pain, not just in EDS, but in other non-EDS patients also. Often, I get a lot of referrals from neurologists that they'll say, oh, I'm sending this patient to you for headaches. We've tried everything, nothing has worked. And then when they come in, then you find out that they have TMJ issues. So I'll talk a little bit about that. These patients also have blurry vision, and that's because of POTS or dysautonomia. So they have, some days they have blurry vision and some days they don't. We'll talk about POTS and dysautonomia, what happens in there. Tethered cord syndrome is another reason for causing headaches. And this is a mystery because it doesn't quite add up why tethered cord syndrome should cause headaches. But we've seen that patients, when you do a tethered cord surgery with them or tethered cord release, and in some of these patients, not all, their headaches get better. And that's one of the things we don't really understand. CSF leak. These patients develop spontaneous CSF leak, and so they have a low pressure headache. I'll discuss these in detail again. Instability of the cervical spine, so they can have craniocervical instability, or they can have atlantoaxial instability. And then idiopathic intracranial hypertension, that means increased pressure inside the head. So you might say, so the patient might say, my whole head hurts and I see double, and I can feel throbbing in my ears, and it increases when I laugh or cough. For me, this is a red flag. And I often ask them again and again, like, are you sure your headache gets worse when you laugh or cough or have a bowel movement? And they'll say, yeah. Oftentimes it'll be a chronic headache, and then all of a sudden when they laugh or sneeze, it'll be like, ow, it hurt. This is an indication of increased pressure in the head. So the pressure inside the head is so high that any increase in the CSF pressure causes their headache to increase. They'll have double vision. They have a pulsatile. So the tinnitus, the ringing in their ears, pulses with their pulse. Now, in EDS, it can be because of narrowing of the blood vessels. So they may have a venous sinus stenosis, which usually is a transverse sinus. So there are two transverse sinuses in the brain, and one of them is sometimes narrowed, which means that, the principle is simple. Amount of blood going into your head should be the same as the amount of blood coming out of your head. That's the rule everywhere in your body. The amount of blood going into your leg should be the same as amount coming out. If one of them is more or less, then you have problems. So in this case, because there's a venous stenosis, there is an increased pressure in the head because not enough blood is coming out. It can happen from Chiari malformation. I'll show you. The diagnosis, so I crossed out spinal tap because spinal tap in these patients is not reliable. In a non-EDS patients, it might be reliable, but in these patients, it's not reliable because their dura matter is so lax. Eye exam, so you can see optic disc changes. You can do an MR venography, which is the best thing to do. And if you suspect it's Chiari malformation, then you do an upright MRI of the neck. And then, of course, the treatments depend on what the problem is. Like I said, there are medicines, you can do a shunt or surgery for Chiari malformation. My headache gets worse when I stand and almost goes away when I lie down. So the key point here is that it goes away when I lie down. Most people who have headaches when they lie down feel better. I have a headache, I get a migraine even, and when I go and lie down in a dark room, I feel a little better. But this is not what I'm talking about. I'm talking about the headache goes away, like zero headache. That's where, so when they stand, it's like a 10 out of 10 headache. When they lie down, it's a zero headache. And when they say yes to this, I ask them again and again and again to be sure, because that changes the game a lot. So you know that CSF flows I'm just trying to find out where the laser is. It's probably down here. Okay, so can you see my laser pointer?
Yes.
Okay, so you know that the CSF flow in the brain and the spinal cord is a closed compartment. That means there's no CSF coming from outside or no CSF going outside. It's produced in the brain, and then it goes down through the hole at the bottom of the skull, which is the foramen magnum, and then it comes into the spine and it flows out. Now, if there is a hole anywhere here in the spine or anywhere, or even in the skull, in the dura mater, anywhere, then this CSF starts to leak out. When it leaks out, then the pressure inside drops. And when the pressure inside drops, the brain sinks down. And actually, you can see it on an MRI, and it's called boggy brain. That means that it's a boggy, like a soft, and it drops down. But oftentimes, because they have a leak, so when they stand up, the leak gets worse. When they lie down, the leak gets better. And so that's the reason why their headache gets better when they lie down. And this is called a spontaneous CSF leak, because oftentimes you ask them, did you get a lumbar puncture? Did you get a spinal tap? And the answer may be no. And these patients do tend to develop spontaneous CSF leak. And this is critical to know because the treatment for this is different from anything else. And it should not be mistaken for a migraine headache or any other type of a headache. So oftentimes the easiest thing is to increase their oral fluids, give them a lot of caffeine. They can do an abdominal binder. And if all of these don't work, then an epidural blood patch. Some people do a fibrin glue epidural. And if it is after a surgery, then the tear is so big that they have to go back and surgically repair it. But I know I don't do any of this, and I don't think you guys do this also, but recognizing that this is the diagnosis will help a lot. So you can tell the patient, listen, or you can call the doctor up and say, look, this patient seems to be presenting with a spontaneous CSF leak headache, and this is what I have seen. And that helps a lot. Treating a patient like this is a teamwork, and working with doctors is key over here. So if I get a call from the pharmacist or a physical therapist, I listen carefully because they've seen something that I didn't see or I didn't pay attention to. My headache gets worse when I cough and I have tingling in my hands and feet, and I have difficulty swallowing. So remember I told you about this, when they cough or they laugh or they have a bowel movement, their headache gets worse, and then they have paresthesias in their hands and feet and difficulty swallowing. This is a manifestation of Chiari malformation. Now, Chiari malformation is fairly common in these patients. So this on the left is a picture of a normal brain. You can see over here. See, this line is the hole at the bottom called the foramen magnum. And at the occipital base, you have the cerebellum, which is responsible for balance, coordination and all that. And the part of the brain that comes out to the foramen magnum is called the brainstem. And the brainstem is important for many important functions, autonomic function like maintaining your heart rate, blood pressure, and all that. Now, and so what happens is everything gets cocked. It gets tight into this, into the foramen magnum, and it gets blocked. When it gets blocked, the CSF flow inside continues, and it increases the pressure inside the head. So these patients present with intracranial hypertension.
Would you mind just repeating the last thing you said? I'm sorry, I got stuck for a second.
Yeah.
So,
no, I don't mind explaining again. So this is Chiari malformation. On the left, you see a normal brain. There's the foramen magnum at the bottom. You have the cerebellum at the back. And so through this foramen magnum passes the brainstem. This part of the brain is called, which becomes a spinal cord, is called the brainstem. And the brainstem is responsible for many things. There are many centers in it, including maintaining your blood pressure, breathing, your heart rate functioning. Everything is those vital centers are there in the brainstem. And this is the cerebellum, which, as you all know, is responsible for coordination, movement, balance. Now, in Chiari malformation, for whatever reason, the brain starts to push down. And when it pushes down through that hole, everything gets plugged. And so when it gets plugged, one of the problems is that the CSF pressure, because the brain continues to still produce CSF. And so the CSF pressure inside the brain increases. And as it increases the pressure inside the head. So these patients present with symptoms of raised intracranial tension, which is the headache gets worse when they cough or laugh. They also present with other issues because their brainstem and the cerebellum is tightened over there. And those symptoms, these are the symptoms of Chiari malformation. So the ones in the red are the more important ones. Like I said, headaches get worse with coughing and straining. They'll present with also a suboccipital headache. They have neck pain, they have balance problems because the cerebellum is being affected. They have paresthesias to their arms and legs. They have dizziness because the center that controls the blood pressure is right there. They have difficulty swallowing and poor hand coordination. So these are some of the problems these patients have. And they classically also have a very suboccipital headache. It's in the back of the head. So the diagnosis of Chiari malformation in EDS is a little different. So of course, getting a good history and physical examination is important, which you guys are experts at. But the problem is that you need an upright MRI of the neck. And that's a controversial thing. A lot of places, even in the United States, don't have upright MRIs. The reason is that when they're lying down, they are in the most normal position they can be. But when they stand up, because their ligaments are loose, the skull kind of settles down. It's called cranial settling. So it settles down. When it settles down, then the brain starts to push through the foramen magnum. And that's why it's important to get an upright MRI. And there have been studies that have shown doing an MRI in the supine position in the same patient versus doing it in the upright position, they can see Chiari malformation. So this is an important reason for pain in headaches and pain, other pains in patients with in EDS. It's called temporomandibular joint dysfunction. So the TMJ is a very weak joint anyway. We all have, it's not a very strong joint. It doesn't have a lot of muscles around it. And so what happens is that in temporomandibular joint, it's not the dislocation of the joint that matters. What happens is these patients clench their teeth a lot. They clench, they grind. So they're using their masseter and the temporalis muscle a lot. These are your grinding muscles, the masseter muscles. These are your temporalis muscles. That's also a grinding muscle. And because they clench all the time, for whatever reason, it could be because of pain or because they're just habituated, we tend to, there is a reflex. When we clench, we get that little extra boost of energy. So like when you try to lift something heavy, you clench your teeth and you can lift it up. But these people clench a lot all the time. And because they clench, they present with pain on the side over here. And then it can even go down to the neck and back. But obviously, they are going to present with headaches. And they'll say, my headaches are on the side of my head. And if you palpate that muscle, if you palpate the temporalis or the masseter, you can actually feel muscle bands. And they'll say, oh yeah, you go transversely over the muscle and you'll feel muscle bands, and they'll complain that hurts. So this is temporomandibular joint pain, and the treatment is a little difficult. So they'll often explain grinding is not common, but it's more clenching, and they have pain with chewing. They have difficulty opening their mouth wide. One of the things that they do is you can adjust the mandible because sometimes the mandible is a little off compared to their maxilla, and so you can adjust that. The other thing that I like, which responds very well, is that you put a warm pack over the masseter muscles and the temporalis, and then you can do a massage. So this can be either from outside for the temporalis and the masseter, or I'll show them that you can put your thumb and your finger like that. So you put your thumb and your finger and you can actually massage the temporalis muscle. Trigger point injections or dry needling is another very good way to go. If all of these start to fail, then I'd also try Botox injections. So what that does is it kind of weakens the masseter a little bit, weakens the temporalis a little bit. So even when they clench, they're not clenching as hard. If all else fails, then they'll need to see an orthodontist who can make this. They make these appliances that you put in your mouth, and it's sort of, when you clench on air. So these are some of the treatments for TMJ pain. So classically, what you're looking for is patient presenting with bitemporal headaches. And oftentimes these headaches are worse in the morning. So you can ask them, is your headache, are you guys okay? Do you need me to, do you need to address? Huh? Okay. They complain of, you can ask them, like, is your headache, do you get headaches when you wake up? And they'll say, yeah, because they've been clenching all night, so they often have a headache on the sides of their head. So moving on to upper back pain. So upper back pain, I'm talking about this upper trap area. They often have shoulder instability. That's because a lot of your rotator cuff muscles are there. Rib subluxations can do it. POTS can do it. And POTS causes a classical, it's a very typical coat hanger distribution pain. So imagine the hook of the coat being here in the neck, and then it goes down like this. And it's funny because I don't know why POTS causes this coat hanger pain, but when you palpate those muscles, I don't find any like muscle knots or tightness, but yet they have pain there. And in women, it can be because of weight of the breast tissue. So, we have ligaments in the front that pull us forward. And then we have ligaments in the back that pull us backwards. And there's a nice balance. In people with EDS, what happens is the ligaments in the back are loose, the ligaments in the front are loose. And so they don't really have a good balance. If you add the weight of breast tissue on it, they tend to lean forward a lot more. And then their muscles in the back are working harder to hold them back. And by the way, this is an issue that's also in non-EDS patients. So oftentimes women do come in, non-EDS patients, they'll come in and they have all this upper back pain and they just can't make any progress with it. And at this time, it's one of the things to consider is if they really do have very thick or big breasts, then we talk about getting a mastopexy or a mastoplasty. So for upper back pain, the first thing to do is correct their POTS if they have a coat hanger pain. If in women, you can do a sports bra with a racer back. So what it does is it sort of holds the shoulder back. So instead of slouching forward, it sort of holds them back. But what works even better is a compressive vest. So you can get these vests both in departmental stores and in medical supply stores. There's a compressive vest and it holds their thoracic spine. It supports it. It's not holding it, but it kind of supports their thoracic spine so that they don't slouch. This is an example of what I was talking about, compressive vests. And they come in different styles. I know this picture isn't that clear, but they come in different styles and different types. There's a British company, it's called DM Orthotics, and they do a really good job of making them. But you don't have to go to this company. There are garment stores, like there's one company that I don't know if it's there in Israel, it's called Leonisa. They make, or companies that make clothing for women, or especially undergarments for women, they'll have something that'll sort of give their body a shape. It's called shapewear, and it'll give their body a shape. So it's like a very tight, compressive garment, and that helps a lot. Neck pain. So neck pain, there are lots of reasons for neck pain there. So you can see that the neck is a set of vertebrae that are stacked on top of each other, and they're all held together by ligaments. And on top of that, you have the head. And the head in the neutral position weighs about 11 pounds, which is the same as a bowling ball. And once you lean forward by about, I forget the numbers, if you lean forward by an inch, the weight on the neck becomes double, or 22 pounds, and so forth. So that's one of the reasons they may have laxity of the ligaments here, the weight of the head pulling them forward. And then, of course, the muscles. If their spine is unstable, then the muscles start to hurt because these muscles are trying hard to hold you in place. The one of the questions that triggers my, oftentimes I'll ask them, hey, does your head feel too heavy for your neck? And they'll say, yeah, it does. And it usually happens by the end of the day when they've been up and out a while. They find that their head feels too heavy for their neck, and they tend to sit exactly like this picture over here, with their chin resting on their hand or their head resting on the back of a couch, because they're trying to take the weight of the head off their neck. And so because the ligaments are loose, their head cannot be supported so well. So what happens is their muscles in their head in their neck are working hard to hold them up. And so often you'll see this. Now, here's the thing. In this case, when most of us, physicians, when they feel the muscles in the neck, they'll say, oh, your neck muscles are really tight. And that's the problem why you feel this. But the problem is that the muscles are tight because they're holding your head up. And if I give them medicines to loosen up the muscles or do whatever injections to loosen up their muscles or something, I'm actually doing them more harm. So the neck muscles are tight for a reason, and the reason being that they're supporting their head. So oftentimes a supportive neck collar can help, and I'll show you an example later on. So we talked about this, the ligaments are loose. So cranial is also, because the ligament in the loose, the cranium, the head settles down when they stand up. And it produces what is called a false Chiari malformation. And so that's the reason why I was talking about an upright MRI. This is just to show you craniocervical instability, and this is an MRI, and you can see how much they can flex this is extension of their neck, and you can see how much they can extend their neck. And here's a spinal cord that gets overstretched. You can see that.
I'm sorry, we have a question about the last slide. Would you mind going back to the last slide again? Thank you, I'm sorry.
What happened?
About the false Chiari malformation.
Oh, what's the question?
If you could explain the cranial settling again.
Oh, sure. So remember I told you the head weighs the average head weighs about 11 pounds. And right now I don't have EDS. So I can hold my head up on my neck easily because my ligaments in my neck, my cervical spine are tight and they are supporting my head very well. Now in patients with EDS, what happens is the ligaments are lax. So when they stand, the head sinks down a little bit because the ligaments are lax. And when it sinks down, it actually pushes the lower part of the brain gets pushed because it sinks down. The lower part of the brain, that is the brainstem and the cerebellum, gets pushed down to the bottom of the skull or the foramen magnum. And that's often referred to as a false Chiari malformation, which means that when they lie down and you take an MRI, they don't have a Chiari malformation. When they stand up, you take an MRI, they have a Chiari malformation. But the word false is incorrect because they are still symptomatic. That's the problem. And so they still have the intracranial hypertension, they still have the balance problems, they still have all of those. Now, do you guys have upright MRIs?
I don't think so. No. I don't think so, right?
I don't, even over here, we don't have too many of them. There are few. But this is something that you'll have to think about. So instead of, if the MRI shows they get a supine MRI, they have no Chiari malformation, but their symptoms are very symptomatic of Chiari malformation. This is something that they'll have to think of, is that are they developing what is called a false Chiari malformation, which means that when they are upright, the skull settles down and it develops a Chiari malformation. That's the issue here. Unfortunately, I don't have a great answer without an upright MRI. That's one of the problems.
Can I ask you another question, please? In a true malformation, Chiari malformation.
What's the question?
Down as well. In a true Chiari malformation, would they see it when the person is lying down or only upright? That's my question.
So in EDS, they mostly see it when they're upright. They don't see it supine. If it's a huge Chiari, of course, they can see it in supine also. But if it's a small to moderate Chiari, then they'll only see it when they're upright. That's the issue problem here. And we have this issue over here because we also have this problem with neurosurgeons. There are neurosurgeons over here who don't believe in upright MRIs. And then there are neurosurgeons who do believe that it shows up on an upright MRI. But studies have shown again and again that the same patient in the supine MRI and the upright MRI, you can see how they develop a Chiari malformation. Because the skull settles down, their ligaments are so lax, it settles down, and you can see the brain trying to push through the foramen magnum. But that's the reason why I said a history and physical examination is extremely important, because that is where you get all your answers. For almost any condition, 70% of your answers come from a very good history and physical examination. So we were going to talk about craniocervical instability. Now, the thing is, in instability, you want to see something in motion, because if it's still, then you don't see anything. I'll give you an example. If the wheel on your car is loose, and if it's parked in your parking lot, you'll not know that it's a loose wheel. You'll only find out when it's moving. When the car starts to move, then you see the wobbling wheel. It's the same thing here. When they have an instability, if you take a static picture, then it's not going to show up. So what you need is what is called a dynamic picture. So like I said, static pictures are not helpful. One of the things they can do is called a digital motion X-ray. So it's like a fluoroscopy, but these patients then move their head under X-ray guidance, and then they can see how the vertebra move in relation to each other. This is fairly common. It's not that hard to find. If they don't have that, then you can do a CT scan, what's called a functional CT scan. So you get a CT scan in a flexion position, and then rotation to the left, rotation to the right, and then you can see how the vertebrae are moving, and they can figure it out whether there's instability of the spine or not. It's very remarkable. Like, for example, in this case, this is an MRI, of course, and you can see how remarkable this patient, what kind of instability this patient is having. His spinal cord is getting compressed over here. So, and then you can get a functional MRI, but the easiest, most available would be a digital motion X-ray or DMX or a functional CAT scan. Managing, if it's a mild to moderate instability, then you can do neck muscle strengthening exercises or using a hard cervical collar. Now, hard cervical collar, I don't usually recommend that they wear it all the time, but I'll tell them, like, listen, by the end of the day, when your head is feeling too heavy for your neck, you can put it on. So what the collar does is, I'll show you here. What the collar does is it takes the weight of the head and transfers it to the thoracic cavity. So the weight of the head is being transmitted to the thoracic cavity. And so it's not putting any pressure on the neck. So these people can actually move their neck, their neck muscles do move. So they can turn and look around, but it takes the weight of the head, and they don't have to wear it all the time. They can wear it only when they're home. And it's like their head is really towards the end of the day when the head is too heavy for their neck.
How would you define, can I ask, how would you define severe instability? How do we know when to refer out or when to say, how long should we give rehab for cervical instability?
So so one of the tricks I do is I put my hand under their skull. So I'm just going to demonstrate. I put it from the back. They're sitting and they're relaxed, and I put my hand around their neck, and my index finger is under the mandible, and I do a slight manual traction, very slight manual traction, and then I say, do you notice any difference? And in instability, they're going to notice a huge difference. Like their vision gets better, their dizziness gets better, their breathing gets better, their pain gets better. So that's a trigger for me to think of instability. And oftentimes I'll repeat it 2 or 3 times, because sometimes they don't notice as much of a difference the first time. So so here's how you do it. there's a person sitting in front of me, I'm behind them. I put my hand around their neck gently, and then my index fingers are under the mandible, and I very slightly put a slight traction, and and they'll notice a difference right away. That should be your trigger that this is cervical instability.
Well,
Then
when would you consider rehab though? When would you consider rehab, and when would you say to send them out for surgical evaluation?
well, if it's, this is a tough question without an MRI or a CAT scan to show you what the instability is. But if they're very symptomatic from instability, like their neck pain is very severe, and their head is just too heavy for their neck, they have difficulty swallowing, these are some of the symptoms of cervical instability, then you should get it investigated. My suggestion is that it's hard to recognize when it's a severe instability or a moderate instability. Mild is easy. They're not super symptomatic. It's better to get it investigated before starting rehab. That's one of the things you can do, because you need to get an answer. If their instability is very bad, then you want to hold off on rehab, and that's the question. And if you're not sure, it's better to get it checked out and get an approval from the neurosurgeon and say, all right, the cervical instability is not that severe, or the patient does not have instability, then you can continue with the rehab.
Thank you.
But don't try to judge clinically how severe it is. I cannot judge it clinically severely how it is, unless I have the pictures. But mostly what I have seen in patients who are very severely unstable, they're very symptomatic. They're extreme. They cannot even sit up for 2 minutes. They'll keep lying down. Their POTS is out of control because it has tons of POTS. Their vision is blurry. Their fatigue is out of control. Their brain fog is really bad. They have difficulty swallowing. These are some of the symptoms of severe instability. The mild instability will say like, yeah, my neck hurts. It's mostly in the back over here. It gets worse towards the end of the day. And I generally tend to sit like this at the end of the day, or I tend to lean my head on the back of that. And that's mild. And you can continue with rehab. But if you have any doubt or question, go to the neurosurgeon, let him or her decide whether this is a severe or not, and whether you can continue with rehab. Do you guys do craniosacral manipulation?
So sorry, the osteopaths here do, right? We have an osteopath right here. Physios don't generally.
Say that again.
I said some physios do.
Some, yeah. Same here. Some of them do, and that's a very good. It is a good technique to help these patients. Like if the surgeon says, "Oh no, I can't. This is not severe," but the patient is still very symptomatic, then I've often seen that they do well with craniosacral manipulation. So these are different types of. This is called the Vista multipost. This is the Miami J collar. These are some of the different types of collars they can get. So what does the cervical collar do? One of the things is that the problem here is that these patients have ligament laxity, and that causes cranial settling. So the brace stops the cranial settling. It stops the head from settling down on the spine. So it kind of gives it a little help, and it transfers the weight of the head to the chest, to the thoracic cavity. It does not weaken the neck muscles because they can still move their neck, and so they can, but it's moving without any strain. This is the question that sometimes comes up. Numbing medicine, I don't know why. Oftentimes these patients, lidocaine does not work for them. And so one of the things that they can use is called Marcaine or Carbocaine that works for them. So when they get their dental effect. So this is a piece of advice you can give them. Let's talk about tethered cord syndrome since we're on the spine. So tethered cord syndrome means, so on the left, you see a normal spine, okay? And over here, the spinal cord ends at L1, which in a woman would be ballpark a little below the bra strap, approximately. So it's pretty high up, because remember, there are 5 lumbar vertebrae. So L1 is pretty high up, almost near so the vertebra above it is is T12. So it's almost at the junction of the thoracic and the lumbar spine. So the spine ends over here into a little conus. You can see this cone. And then you have a phylum that hangs down. This is nothing but a piece of thread. It's hanging loose. And this is important because when children grow taller, the spinal cord does not get longer. The bony spine gets longer, but the spinal cord does not get longer. So it moves up as the patient gets taller. And you'll see this problem with tethered cord. If you see it in a child or in a young adult, like a teenager, and you try to trace and say, when did your symptoms start? And you'll see that it relates to when they had a growth spurt. A few months after a growth spurt, they'll notice that their symptoms of tethered cord started. But anyway, the spinal cord hangs loose. That's how we are. And so when you move, so when you flex forward, there is no strain on the spinal cord itself. In tethered cord, what happens is that the phylum is attached to the bottom of the spine. So now your spinal cord is being pulled down. It's in under tension. And when it's under tension, then your conus, remember the conus ends at L1, is now gets pulled down to L3. Excuse me. This is often one of the findings you see on MRI. So they'll say that the conus ends at, may not be L1, it might be ending at L2 or near L3. And the other thing is that in older spinal cord, in older tethered cord syndromes, patients are a little older, the phylum becomes thickened. There's a fatty deposition on the spinal cord. And now we started to see, so I have a surgeon, neurosurgeon here, and she does a lot of tethered cord surgeries. And we've been looking at them under microscope after the surgery. And it turns out that the phylum is very, very inflamed. So we're not quite sure why it's inflamed and what's the cause and what pain does it cause. I mean, it obviously sounds like it'll cause back pain, but so the phylum gets inflamed, it gets this fatty deposition on it. So this is a tethered cord syndrome. So in a normal spine, it's hanging loose. In tethered cord syndrome, it's stuck to the bottom. In children, in babies and little kids, it's very easy to diagnose. They may do heel walking, toe walking. They may even have abnormalities on their lower spine. They may have a birthmark on their lower spine. And you can see that they have an immense amount of pain. They're pretty much screaming in pain. But if it's missed and as they grow, then they'll continue to have these symptoms. Low back pain, it's a very non-specific low back pain. You know, if you pick up any adult and you look at their MRI, there's always something going on. But these patients have a low back pain. They have what is called a neurogenic bladder, which I'll explain to you. They have leg weakness and sensory loss. So if you ask them, like, when you walk, do your legs feel weaker? And they'll invariably say yes. They say, yeah, as I walk, my legs start to feel weaker. And the pain in the legs is not in any dermatomal distribution. It's like a diffuse pain in their legs. Like, can you, if you ask them, like, can you point to exactly where your pain in the leg is? And they'll say, like, it's the whole leg that hurts. And it may not be both legs. It could be one leg or the other leg. So sensory loss is not that common. I don't see that often, but it can happen. And oftentimes they'll have sensory loss in the perineum. But these are the common ones: back pain, neurogenic bladder, when they walk, and then they have diffuse non-dermatomal pain in their legs. oh, that's a duplicate slide. So neurogenic bladder, it means that they have urinary hesitancy. That means they'll say like, oh, I have difficulty starting. They may have increased frequency. They go a lot. Can you hear me?
Yeah, thank you.
Okay. Sometimes the internet drops down for some reason. So they have urinary, they have increased frequency. So they'll say they go a lot. And then obviously they'll also say that I drink a lot. That's why I go a lot. But that's not always true. In some cases, they have decreased frequency. They'll say like, oh, I'm like a camel. I don't go for like the whole day. They do have urgency. That means they can't hold it. They have to run. So they're fine. And all of a sudden they need to run. They'll have a sense of incomplete emptying of the bladder. So they're finished peeing and they still don't feel like they've emptied their bladder. They feel like something's still there. In very late cases, you can see incontinence. So they'll have incontinence, not just the regular incontinence like with laughing or sneezing. They'll say, yeah, it just comes out on its own. So this is called a neurogenic bladder, which in brief, what it means is that the bladder is not communicating with the brain. That's what it means. So mostly I look for increased frequency, urgency, incomplete emptying of the bladder. Incontinence is not that common. But here's the thing. In people who have Chiari malformation, 66% of them will also have tethered cord syndrome. So anytime you see a Chiari malformation patient, look for tethered cord syndrome. They're somehow related, and we don't know why they're related, but it's got to do something with EDS. But almost more than half the patients with Chiari malformation have tethered cord syndrome. So how do you diagnose tethered cord? MRI is not a useful diagnostic tool. And this is the problem because there are neurosurgeons, a lot of the neurosurgeons believe that if it doesn't show up on an MRI, it doesn't exist. And that's the thing. The phylum is sometimes so thin that you cannot see it on an MRI. And so neurosurgeons who treat tethered cord in EDS don't always look for an MRI, but you do need an MRI to rule out any other problems that they may have, any other issues that might be causing these symptoms. The diagnosis is based mainly on clinical history and examination. But you also need what is called a urodynamic study that helps. So you can send them to a urologist and they can do what is called a urodynamic study where they look at a neurogenic bladder. So they'll say that this patient is not emptying their bladder enough, or this sphincter control is not good enough. That's called a urodynamic study. So the history that I just talked about, plus the history that I talked about, plus the neurogenic, the urodynamic study, all of these combined should trigger thoughts of tethered cord syndrome. One of the things that I've learned over the years is that tethered cord syndrome surgeries work well in younger patients. So like up to about the 20s, they do well. But after that, in the 30s and above, the surgery doesn't really help a lot. It helps with the bladder symptoms, but it doesn't help with the pain as much. So I'll often give them, if their bladder symptoms are very severe, then I'll recommend a surgery. But if their bladder symptoms are okay and they're fine with it, then I'll say like, hold off on the surgery because it's not going to make a big difference. But if they're younger patients up till the teens, even the 20s, I'll say it's worth going in for surgery. Abdominal pain is extremely common in EDS. I mean, it's like almost 99% of patients with EDS will have abdominal pain for many reasons. I can't go through all the reasons because of time, but I just want to bring that up. Be aware of this. So they have gastroparesis. They'll say that when I eat food, my stomach gets bloated. And sometimes it's to very specific foods that their stomachs get bloated, like gluten foods or dairy or meats or something. They start to have bloating of their stomach. They have slowing down of the intestines. They can also develop what is called median arcuate ligament syndrome, or MALS. This is an extremely painful condition. In this condition, the celiac plexus and the celiac plexus gets pinched by a ligament inside. And the symptoms of this is that they have severe pain in the epigastric region as soon as they eat food. So that, if they say that, that triggers my thoughts of median arcuate ligament syndrome. Males, they'll have pain in the epigastric region. In fact, if you palpate the celiac plexus, which is in the epigastric region, they'll complain of like severe excruciating pain. POTS can cause abdominal pain. It causes nausea, acid reflux, bloating, constipation. I actually didn't put in here, mast cell activation syndrome can also cause abdominal pain. We'll talk about that. Besides that, they have diverticulosis and prolapse. That's common. So subluxations and dislocations. I want to show you the difference between the two. In subluxation, and that is that most patients with EDS have subluxations. They don't have dislocations as commonly. And the subluxation is that there's an overstretching of the capsule. It doesn't tear. So I call subluxation a slippery joint. So if this is the joint slips out and slips back in. And sometimes they'll say like, oh, I do it 10 times a day. And I asked them, because a lot of patients with EDS don't know this. So I'll ask them, look, this is the joint, it slips out, slips back in. When it slips out, you'll feel as if something is not in the right place and it hurts a lot. And then you do a little movement and it goes back in place and the pain is better and everything seems right. And they'll say, oh yeah, I have, my shoulder does it, my knee does it. That's a subluxation. A dislocation is where there's actual capsular tear and the joint comes out and it stays out. And then it has to be manually put back in place. And now, it's not common, but there will be patients that you'll see oftentimes will come in with a dislocation, a hip dislocation that actually they won't know have a dislocation. You'll be able to see it. They might have a hip dislocation or a shoulder dislocation. A hip dislocation is very easy to replace. You tilt the foot end of the bed. So you angle the bed so their head is down and their feet are up. And then that's their traction. And then you do a counter traction by pulling on their ankles very gently with just your body weight. And all of a sudden, the muscle lets go and the hip joint pops back in place. The shoulder joint is a little tricky. That you'll have to send them to the emergency room and they can put it back in place. But most patients with EDS can put their joints back in place by themselves. And subluxation is way more common than dislocation. So I don't want you to think that, oh, this patient doesn't have any dislocations, hence it can't be EDS. In fact, subluxations also is not in the diagnostic criteria for EDS. So we just talked about this. Rib pain, you're going to see this a lot. And you can do a lot also over here. So rib pains are because of rib subluxations and costochondritis. Let me talk about rib subluxations. So if this is, imagine this is the thoracic spine. And this, I don't know if you can see my pen. Yeah, there it is. So if this is the thoracic spine and this is the rib, and you know the rib makes a connection at the thoracic spine. There are three little joints called the costotransverse joints. Now, this is where it meets. And when I slouch, then everything moves. So if I slouch, then everything moves with it. But in patients who have EDS, if they slouch, then the rib pops out. So if this is my thoracic spine and this is the rib, this pen is the rib. And if I slouch, then my rib moves with the thoracic spine. But in EDS, what may happen is that when they slouch, the rib pops out. And it's very painful, very, very painful, because it pushes out the muscles around the back, go into a spasm, then the intercostal nerve gets irritated, so the rib pain goes to the front. And that's that's rib subluxation in these patients. And you'll see that as physiotherapists, you'll see that a lot. And this is what I was trying to show you. When they're in a slouched position, the rib subluxes out, and they go into a slouched position a lot because their ligaments are not that strong, they're elastic. So they tend to, I can sit like this without any problem. But for them, they have to make an effort. And after sometimes their muscles get tired and they start to slouch. And that's when the ribs start to pop out. This is one way. So in an acute subluxation, this is one way to push the rib back in place. So they can go on a roller, a hard roller, and this literally pushes the costotransverse like joint or the rib back into place. Since you guys are physiotherapists, you can even do it manually. You can pop the rib back into place. That's one way to do it. Another one is the cat stretch. I'm not sure how well this works, but if the patient is at home and doesn't have any access, they can try this. But I doubt if this works so well. This works really well. But to prevent it, you have to prevent it. The way to prevent it is to have them keep their thoracic spine aligned. And to keep it aligned, of course, you need to keep the muscles strengthened. So your core muscles, they need to be kept strong. Also, to help them, because their ligaments are so lax, they can try some of these vests, orthotic vests, that hold them in place. Just a tight vest you can buy at any garment store. This is a company that makes it, so I put it there. But you can any garment stores for women, they'll have that there. You know what I mean?
Hold on, we didn't hear you. Can you repeat that? Just froze up.
Say that again?
Yeah, oh no, we just froze up for a second, the internet.
Oh yeah, it stops for a minute, sometimes it loses it. So what I was trying to say is that this is acute management of rib subluxation. This you can do, or you can do a manually push it back in place. This is another one which I'm not so impressed, but this is to prevent rib subluxations, to keep their thoracic spine aligned. It's not easy to tell them like, okay, don't slouch. They cannot, because their muscles, their ligaments are just not strong enough. So they need help by using these compressive garments. So shoulder joint is a really common cause of pain you'll see because the shoulder is actually not a very stable joint in general. It's any joint that has a lot of range of motion is never a stable joint. That's the problem. Like the hip joint is a very stable joint, but it doesn't have much of a range of motion. Whereas the shoulder joint has a lot of range of motion. And so the shoulder joint subluxes quite often. But one of the things that happens because of the instability of the shoulder joint is that they develop what is called thoracic outlet syndrome. The pattern in thoracic outlet syndrome is exactly how it would be in somebody with cervical radiculopathy. It look like the penis coming down their upper back to their hand, their arm, and into specifically more into their fingers. Specific dermal distribution. It might be in the thumb and the finger, or these three fingers, and it often radiates to the anterior chest. So what is thoracic outlet syndrome? So as you know, the first rib is a very flat rib. It's very flat. And on top of that, the collarbone. And between the collarbone and the first rib, there is a gap. And in that gap, you have the brachial plexus. Not only do you have the brachial plexus, you also have the scalene muscles in there. So you have the brachial plexus, and you have the veins, and you have the arteries, and you have the scalene muscles. Now, because the collarbone is connected to the shoulder joint, it tends to become unstable. And if the shoulder joint is unstable, the collarbone becomes unstable. When that happens, then this gap between the collarbone and the first rib closes down, and it compresses it can either compress the brachial vein, the brachial plexus, which is called neurogenic neurogenic thoracic outlet syndrome, or it can compress the veins when it's called venous thoracic outlet syndrome, or it can compress the arterial when it's called arterial thoracic outlet syndrome. The arterial one is rare. So is the venous. It's not common, but the most common is neurogenic thoracic outlet syndrome. So these patients will complain of pain going down the arm, or they'll have pain in the arm, or they'll have tingling in their paresthesias in their hands. There are some tests for it. You can, I don't have the time, but you can look it up. You can do these are some clinical tests that you can do in the office. But also remember that the brachial plexus travels behind the pec minor muscle. So this is the pec minor muscle, and it travels behind it. And what I do is I put my hand in their axilla and I grab the pec minor muscle, and you can feel muscle knots, and they'll say, yeah, that really hurts a lot. So that tells you that the pec minor is in a spasm. You can do a percussion above the clavicle or below the clavicle, and you can do a percussion which is called Tinel sign, and they'll complain of pain going down their hand. They'll say, yeah, when you do that, when you tap over the brachial plexus, the nerve goes, they feel that paresthesia in their hands. Now, in terms of, and of course, if the scalenes also, you'll feel the scalene muscles very tight. The role that you can do in here is to start to work on loosening up the pec minor muscle or the scalene muscles. Thoracic outlet syndrome in EDS is common, but it is not often severe. It's not often that I'll send these patients to a specialist for this. In the non-EDS patients, I will, because there it's a different story. But as physiotherapists, what you can do is you can work on the pec minor to loosen it up. You can work on the scalenes to loosen them up. And that will help a lot, will make a big difference to these patients. So the treatment regimen protocol for this is to try kinesiotaping. I didn't put, because my audience is usually patients, so I didn't put in the work on the pec minor and the scalene muscles, but kinesiotaping is one way to go. If that doesn't work, they can do Botox injections into the pec minor and the scalene muscles. And that actually works very well. In almost 70% of the cases, it responds very well. If nothing works, then they have to do a surgical correction. Now, in rare cases, they may have an extra cervical rib, and that you can detect on an X-ray. But mostly it's because of an unstable clavicle. That's when these patients develop these symptoms, or an unstable shoulder joint, and they'll have spasms of the pec minor and the scalene muscles that causes this thoracic outlet syndrome. Their pain patterns are like this, palpating the scalene, even pushing on the scalene. If you push on the pec minor, they'll say that I can feel the tingling in my hands. So these are some of the things. This is just, I'm sure you're all familiar with kinesiotaping. I love kinesiotaping. It's an amazing technique to use. And the problem is that EDS patients don't tolerate the adhesive glue. But if they do, then use kinesiotaping as much as you can. It's an amazing technique. One of the issues with EDS we talked about at the beginning was joint position sense, also known as proprioception. This is where the body's ability to sense movement of the joints in their position, because your brain has to know exactly where every body part is. Every muscle that's working, your brain has to know. That is the way it controls how we walk, how we talk, how we stand. The brain has to know, and then it has to send the signals to the muscles. That's the control center. If the brain doesn't know where your muscles are or where your joints are, then it cannot send any signals to help you. So there are sensors in our joints, tendons, ligaments, muscles, skin that tell the brain constantly where your joints are. For example, if I have an itch on my head, I can scratch it without looking at my head. I can close my eyes and still scratch it correctly because my brain knows where the itch is and it knows where my hands are. And so it sends a signal and controls that. That's walk. So every time I lift my right leg, my brain knows how high it is. It sends a message to my left leg and balances me. People with poor joint position will sometimes tell you that they bump into doorways, they trip on stairs while walking up because every step is 6 inches and their brain doesn't know whether the foot is 6 inches above. And so they tend to trip on the stairs. So this is how we protect ourselves. This is how we move. And this is also how it avoids us from hyperextending joints, because once we start to hyperextend, then the brain says, okay, stop, you're hyperextending, you're going to cause damage. And so you don't hyperextend as much. The problem in EDS, actually the problem with anybody with anybody with joint issues will have poor proprioception. And I'll show you, this will apply not to just EDS patients, but in your non-EDS patients also. In sports injuries and the elderly, you'll see that they have poor joint position sense. So this is a graphic I wanted to show you. So as this step up here, signals travel up the spinal cord to the brain, and then the brain then sends out message to your arm so you can balance yourself. It sends a signal to your other leg to help support you as you walk. Remember, we walk only on one leg at a time. So one leg is on the ground, but the other leg is in the air. So your brain has to balance all this out. Loss of proprioception is not just in EDS. You can see it in toddlers when they're learning how to walk. They don't have a good joint position sense, so they tend to fall a lot. In elderly, it is joint degeneration. Athletes, it's because of joint trauma. And even in patients with post-joint surgery. So not only, I know you guys work on post-joint, joint replacement surgeries or joint surgeries patients. We talk about strengthening their muscles or getting physiotherapy. The key thing here is to get their proprioception back. That's the key thing here. This is, again, I wanted to show you. Now, when the brain doesn't get signals from the rest of the body, then it uses contact with skin as a way to figure out where the joints are. So for example, if my hand, if my knuckles are not getting enough sending signals out, if I wear a glove, a fingerless compression glove, then the brain uses signals from the skin over the joint to figure out where the joints are. That's how it does it. So there are two ways to do it. One is signals from the joint itself, from the skin over the joint, and the other one is visually looking at it. So you'll see people with EDS when they walk, they tend to generally look at the ground, or they scan everything around them as they're walking, because that's how they get their input. So wearing skin tight clothes makes a lot of sense. It doesn't have to be extremely tight. This is for the people who really have a poor joint position sense. But anything that is skin tight will do fine. And oftentimes I'll tell patients, buy yoga pants or buy Spanx or something that just sort of clings to your skin. Like for the torso, I'll also say buy a swimsuit, a single piece swimsuit, one size smaller. And so they feel that gives them a lot more sense of their position in space, a spatial sensation. And EDSs don't have a good sense of space around them because their body doesn't know where their body parts are. So this is a very nice company. Again, I don't have any financial interest, but this is a very nice company that I found, makes custom sized garments for patients with EDS, works remarkably well. If they don't have access to this, then any garment that is skin tight will do. So because they're not getting signals, one of the things is that if they pick up a glass, a bottle of water, and they start to talk to someone or they are doing something, the signals from their knuckles, the brain doesn't get any signals from their knuckles. And so what it does is lets go. And so they tend to drop things a lot. And I always tell them, listen, on your cell phone, get a ring at the back of the cell phone or get a pop socket. Or when you're holding coffee or water, make sure that there's a handle on it. But they also do the opposite. They sometimes hold things too tight. So they may have when children, they hold their pen differently. They hold them with many fingers. They hold them really, really tight. And when they write, they press hard because there's no sensation coming from the brain. So they overcompensate. So people with EDS go both ways. They'll either drop things or they hold things tight. And so that's one of the, plus they also have laxity of their fingers, which means they have jello fingers. And so when you hold something, you have to make your fingers rigid. So if I have to hold this glass, I have to make my fingers rigid. But because their fingers are lax, they don't get that rigidity easily. They need to work harder, which means that the muscles start to hurt more. One of the workarounds for the hand is to wear a fingerless compression glove. They're often sold as arthritis gloves. To make the fingers more rigid, they can try ring splints. There are many, many people who are making them. You can get ring splints, which gives their fingers and the joints in their hands a little more rigidity. Mostly you need it for these three, the thumb, index, and the middle finger. These two are just for show. But these three, most of our work is done with these three people. So you need it mostly for this. In terms of practical things, kitchen utensils with thick handles help a lot. Like I know there's a company in the US called Oxo. Not sure if it's there in Israel. Do you have it there?
You get it here too. It's Amazon now.
Right. So I've noticed that they make their handles really thick. Like look at this potato peeler. The handle is really thick and cushiony, and this really helps. So buying any utensils, things like that, a knife with a thick handle, or a spoon with a thick handle makes a big difference. With kids who are writing with a pen or a pencil, putting a foam tube around their pencil or making it thicker helps them a lot. You can get rubber attachments that will fit on these pencils. So one of the arguments that I hear a lot is that braces make muscles weaker. And this argument has been passed down again and again, and no one knows the answer. So I looked into it a little bit more. And here's the thing. The braces don't make muscles weaker. In fact, they do the opposite. They make the muscles stronger. It's a common misconception. So braces are not tight enough to stop muscles from moving. For example, if you put a knee brace, the brace is around the joint. It's not around the muscle. And so if your knee is not stable, then the patient will tend not to walk. So they're not going to use their muscles. But if you stabilize their knee joint, then they'll tend to walk more. And so their muscles tend to stay stronger. So braces actually make muscles stronger. This misconception started from plaster casts. So when people had a broken bone, they would put a plaster cast, and it would be from the proximal joint to the distal joint. And then after 3 months, when you take off the cast, you'll see atrophy of the muscle. That is different. That is you're purposely stopping any movement of the muscle. But over here, we are actually encouraging movement of the muscles. And I've had this argument with physicians a lot. They keep telling their patients, oh, you shouldn't wear the brace all the time. But then if they don't wear their brace, they can't walk. They can't move. So this is, I mean, I don't encourage that they wear it 24 hours, but I do encourage that they wear it as often as they can, as long as they're moving. So I'm going to talk to you about pain in the lower half of the body. This is a graphic where if your ankles and feet are not stable, then that makes your knees unstable, which then makes your hips unstable, which makes your back unstable, which throws your spine off. So it's like a Jenga tower. if your ankles have to be stable, so oftentimes, this is not just EDS, even in non-EDS patients, if they come in with back pain and I can't find a good reason, I look at their ankles or knees and they'll say, yeah, I have this problem, I have a flat feet, or I have, issues with my knee. And so treating their back is not going to help. Treating their knee is going to help. And same thing with the EDS. You talk about stabilizing their ankles first, then you stabilize their knees, and then their hips. Like I said, the hip is usually a very strong and a stable joint, and it falls in place. So what happens in feet and ankles? There are usually two problems. Either they have flat feet and they have unstable ankles. And it's the unstable ankles that worry me. So they'll often tell you, you can ask them, like, when you walk, do you tend to roll your ankles? And you can see this over here. As they're walking, they tend to roll their ankles. The problem is that when they roll their ankles, it separates the tibia and the fibula a little bit. And that there's a joint over here called the proximal tibiofibular joint. And there's a nerve over here just below the knee laterally called the peroneal nerve. And that peroneal nerve gets inflamed. And so they tend to develop a foot drop. And when you try to get history from them and say, like, okay, do you roll your ankles a lot? And they'll say, yes, I do roll my ankles when I walk. Do you find yourself tripping on your toes? And they'll say, yeah, I tend to trip on my toes a lot. And you can see them. I have them walk up and down my hallway for about 10 minutes, and then you start to see that they're starting to drag their foot a little bit. And sometimes you can see that the tip of the shoe, the sole of the shoe is worn out, and you can see that they've been tripping on their toes. The problem is that these people have very unstable ankles. The treatment is very simple. High top shoes make a big difference. The only condition is that they should have laces on them. So the high top shoes hold the ankle in a stable position, and it's also, the compliance is much better. You cannot have a teenage girl telling her to wear ugly ankle braces. But yes, if you tell them to wear high top shoes, they'll be really happy with it. Just make sure that they have laces on them, not slip-ons. This stabilizes the ankle. The shoe insert, there are many types of shoe inserts available in the market. They can use any, that's fine. Sometimes it's not even advisable to use a shoe insert because they actually feel more uncomfortable. Sometimes shoe manufacturers include a small arch in their shoes, so it's hard to predict. But the things to look in a shoe insert is that it should have a deep heel cup. The material should be solid, it shouldn't bend, and it should have an arch. Among the brands, and there are lots of them out there, there's one German brand that I like, it's called Pedag, P-E-D-A-G. And they do make a really good shoe insert that I found, but it's, you can go to the local store, I tell them, try it out, you should feel good right away. If you don't, then it's probably not for you. So moving up to the knees, they're only, usually you'll have two problems. One is a hypermobile kneecap, or the patella is very hypermobile, or they hyperextend their knee joint. And you can see this, how the kneecap is extremely hypermobile. It makes their knees somewhat unstable. They also hyperextend their knees, what's called the banana knee. And the way to check it is you have them stand with their feet slightly apart, and you have them bend a little bit, lean forward at the waist. So when they lean forward at the waist, they push their knees back, and you can see the hyperextension there. And again, just because they have hyperextension doesn't mean that we have to treat it. So you ask them, are you symptomatic? And this is the tricky part. They may have hyperextension of both knees, but they may say, only my right knee hurts. But it may be possible that the left knee is hyperextending so much that they are overusing their right knee. And that's the tricky part to figure out. Where do you want to put the brace? Should you put it on the right knee, which hurts, or should you put it on the left knee, which hyperextends more. And I usually will go for the left knee because that hyperextends more. And so they stop putting more weight on their right knee. So this is a little bit of a clinical judgment that you have to make. This is the knee brace. The things to look at a knee brace is that they should have this particular brand is a wrap around. So the problem with a lot of the knee braces are that they have to pull it up their feet and up their legs. And because their fingers are loose, it's very difficult for them. This particular brand it wraps around the knee. I like it because it's number one, it wraps around, but you should look for a hinge on the sides, a supportive hinge, which prevents them from hyperextending their knee. And of course, there should be a little donut hole for the kneecap, and then a strap on the top and a strap at the bottom to prevent it from slipping down. So EDS in children, there's a big danger about EDS in children, and the biggest is that it's actually from the medical world. There are ignorant hospitals and doctors, and a child may come in with unexplained bruises because they have soft connective tissue, they have dislocating or subluxing joints, they have chronic body-wide pain, they have abdominal pain, and oftentimes ignorant healthcare providers may point this out as being a psych issue, or they may accuse the patients of being abusive to their child. And this is one of the biggest, this is one of a major issue that we are facing, at least in the United States, a lot. So on this, I often recommend to patients is that before you go to a hospital, check with other patients and see whether this is the place to go or not. Like over here, we are now well aware of which hospitals are EDS friendly and which ones are not. And if you are in a doctor's office and you feel that the doctor isn't believing you or skeptical, then just quietly go somewhere else. I don't recommend going to big academic hospitals, because in big academic hospitals, the first few doctors you're going to see are people who have graduated yesterday. These are interns, residents. They're the least qualified to manage complex medical conditions. So I often tell parents, stay away from children's hospitals unless it's an emergency, or you definitely know there's a doctor there who understands EDS and all the issues that come with EDS. And I also recommend to patients that have your pediatrician on your side. Explain to your pediatrician, this is what's going on. And so if there is a problem, the pediatrician can help them out. So the question is, and there have been papers published recently that patients with EDS have more psych conditions. And so this is a question I've always been asked. The answer is no, they do not. There is zero data to prove that patients with EDS have more psych conditions than anyone else. Listen, they're often blamed with eating disorder. Well, they don't have an eating disorder. The problem is that when they eat, they get bloating, or if they have mouths, their stomach hurts. So that's their problem. Then they say that these patients have agoraphobia. That means they don't want to go outside into crowds. Yes, they're unstable. Their feet are unstable. Their knees are unstable. They have POTS. They have dizziness. They're going to be afraid of going out into crowds because they're afraid if they have a dizziness episode or if they sublux or dislocate a joint, they're going to be in the hospital the next day. So anyway, I wanted to bring that to your attention. Another common thing you see in these patients is dysautonomia, which means dysfunction of the autonomic nervous system. So the autonomic nervous system well. It's the sympathetic and the parasympathetic nervous system. Well, among the dysautonomias, there are many different types of conditions, but the most common condition is called POTS, or postural orthostatic tachycardia syndrome. These patients present with being lightheaded. So they'll say that when they're lying down and then they stand up, they get lightheaded for a few minutes, or they have black spots, or they black out. They have palpitations, heart racing. They have immense fatigue. So sometimes their fatigue is so bad that they can't even function for more than 5 minutes. They may have headaches. Their hands feel cold. Their hands and feet feel cold. They have lots of brain fog. lots and lots of brain fog. They're very forgetful. And they also have a feeling of constant anxiety. So how do you diagnose POTS? You can do that in your office. So you have them lie down for 5 minutes or 10 minutes. You have them lie down, rest up, and then you check their blood pressure and heart rate. Then you have them stand up and wait for 30 seconds and check their blood pressure and heart rate again. And then you have them keep standing for 10 minutes and check their heart rate and blood pressure again. And those readings will tell you whether this patient has POTS or not. Some of the more complex tests are called the Q-sweat test or the tilt table test, this is also called the poor man's tilt table test. It's the same thing, but they do it on a more complex tilt table with more measurements. So if the heart rate increases by 30 beats per minute within 10 minutes of standing, but the blood pressure stays stable, the blood pressure does not change, but their heart rate goes up by 30 beats or more, that's an indication of POTS. Or their heart rate is at 120 beats per minute within the first 10 minutes of standing. There should be no significant change in blood pressure. They should be symptomatic. That means they do get lightheaded, they have palpitations, they have brain fog. In children, the increase is considered to be significant if it is more than 40 beats per minute, change in heart rate of 40 beats per minute. So the question is, if a child comes into your office and you do the orthostatics and their heart rate goes up by 39 beats per minute, so would you say that they don't have POTS? That's often a question we have. And obviously they do. I mean, one heartbeat is not going to make a difference. It just depends on the day and time when you did it. So ballpark, if their heart rate goes up by 40 beats per minute, or their heart rate goes by, for adults, if it goes up by 30 beats per minute, that's significant for POTS. Now, let me explain why patients have POTS in EDS. There are several reasons. One reason is that when we all stand, we pour blood down our legs. And when we pour blood down our legs, my sympathetic nervous system kicks in and it pumps this blood back to my brain. And it provides oxygen to my brain and my tissues. People with EDS do the same thing, but the difference is that they pool more blood because their veins are much more elastic. Their veins are much more elastic, so they pool more blood. And you can see it. If you have them stand, you'll see their feet turn dark red. And if you elevate the foot, it becomes normal color. So because they pool more blood, their sympathetic nervous system is working much harder. That means sympathetic nervous system is the same as the nervous system that controls your flight and fight. So their heart rate is much higher. And that's the reason why we did the tilt table test and their heartbeat goes up by 30 beats per minute. Because their nervous system is trying to compensate for all the blood that's pulling down in the legs. But because their sympathetic nervous system gets revved up, because they have this increase in sympathetic activity, it feels like they're always in a state of flight or fight, which is the same as having anxiety. So it always feels like these patients with EDS have anxiety, but this is not true anxiety. And the way to figure that out is that you can ask them, say, like you're sitting at home, you're doing nothing, you're just watching a movie, nothing's going on, and all of a sudden they'll feel a wave of anxiety pass through them. And that's an indication of POTS. In actual anxiety, for example, if I have anxiety because I'm an anxious person, my heart rate is not high. It's just I feel anxious, but my heart rate is not high. But in these patients, their heart rate is much higher. And very often you'll see their heart rate is like 99, 100, 120. It's pretty high. So because their sympathetic nervous system activity is so high, they have this feeling of anxiety or panic all the time. And the solution is very, very simple. All you have to do is take a bunch of salt and you're good to go. So a lot of my patients with POTS, carry salt shakers in their bags, and they take salt and they drink some water and they're all good to go. So the management of POTS lies in increasing your salt, or you can try a salty diet or take salt pills, electrolyte fluids, increase your water, compression tights, and then there's a medication called ivermectin that they can try. Exercising in POTS. So one of the exercise, so in POTS, the recommendation is usually to do exercise while you're lying supine or reclining. So I mean, you guys are experts at that, but I tell my patients is that if you go on YouTube, there are some really nice videos on doing supine exercises for POTS. If you just put the word supine exercises for POTS, you'll see some really nice videos. And so they can do these exercises while lying flat or reclining. Reclining bike is fine. But remember something, do not push them. Do not push them hard, because their tissue is soft and their tissue will break down very easily. And once it breaks down, it takes much longer to heal. So stay under your limits of exercise. There's technology that these patients can use, like using Alexa to communicate or call for help. Apple Watch, any Apple Watch after 4 is useful to record your heart rate, but it also has a fall warning. So it detects a fall and calls for help. Mast cell activation syndrome is a very painful condition. It feels like you have flu all the time. It adds to fatigue. It causes abdominal pain. It causes body-wide pain. So there's diffuse inflammation in the body, and it also worsens POTS. So mast cells are normally found in our body, but what happens is in patients with EDS, they get activated for some reason. They just start to misbehave, and they release chemicals like histamine and cytokines that cause pain. So they can present with all of these symptoms like brain fog, headaches, heart palpitations, a lot of GI issues. They have a lot of abdominal pain, gastroparesis. They can have burning in the urethra, wheezing. They do have rashes and hives. The treatment is in 3 parts: is to try antihistamines, mast cell stabilizers, and then avoid triggers. So oftentimes these people have triggers that you can avoid. Avoid drugs or foods with color dye, such as red or blue dyes. So fatigue in EDS, there are all these reasons. EDS can call it.
Can we ask you a quick question?
Sure.
About the POTS. If I have a patient who tells me that he feels that his heart rate elevates all of a sudden, when should I advise him to go to a medical place or to an ER? Should he just sit and see, or?
No, they don't need to go to the ER. Their heart rate, you just tell them to lie down for some time and their heart rate will come down.
Is there that it can be dangerous up until from this point or some other point?
No, it cannot be dangerous. There's no risk to it. If the heart rate, so let's say they're exercising and you started at, say their heart rate was 80 when they started, and now they've been exercising for 5 minutes or 10 minutes and their heart rate is now at 140, then you slow down or stop and it'll come down again by itself. Give them some water to drink, give them some salt to take, and they'll be fine. And people with POTS know that. They know that. They know how to manage it. But they're not, their hearts are healthy. There's nothing wrong with their hearts, and they have healthy hearts. There's no reason to go to the emergency room. Just have them lie down for 5 minutes and they'll be fine.
Would you recommend the Dallas protocol?
The Dallas protocol, see, the thing with the Dallas protocol is that it does not take into factor that these patients have weak connective tissue. Their muscles are weak, so they tend to get more micro trauma.
Right.
So I don't recommend protocols as much. I just recommend designing each patient's protocol yourself. You say like, look, this is what you need to do in terms of exercise. You know, make sure, keep an eye on your watch, and don't let your heart rate go beyond whatever number, 120 or 110, or if you get symptomatic, stop. But don't push them. The Dallas protocol really,
What you're saying.
Sorry?
You're saying gradually increase it, but without
Right.
that, but I've ignored their exercise recommendations, but I tried to use the heart rate as a guideline.
Exactly. That heart rate recommendation does not apply here. The Dallas protocol is not meant, it's meant for healthy people, not for EDSers. EDSers have weak connective tissue because if you push these people a lot, they will not be able to exercise the next 2 weeks because their tissue hasn't repaired itself. So always stay under. Always stay under. So in terms of fatigue, there are all these reasons for having fatigue. All of them, EDS, POTS, mast cell, even the medicines they may take, pain, poor sleep. These people don't sleep. And secondary mitochondrial dysfunction. These are the reasons why these people have so much fatigue. The issue is that you have to figure out which one or which ones of these are adding to their fatigue. Mitochondrial dysfunction, I just wanted to quickly tell you about it. Mitochondria are like rechargeable batteries in our bodies, and the problem in these people is because of their connective tissue issues, their rechargeable batteries are not working well. So they lose energy very quickly. And then you have them rest for 5 minutes, they get back their energy, and then they can do some more, and then they lose it again. So this is I just quickly threw in a little bit. Gastroparesis is these patients will complain of bloating after they eat. This is a good drug called prucalopride, which I like. But mostly their GI issues is from mast cell activation syndrome. Median arcuate ligament syndrome, I just wanted to show you, they often have pain in the upper belly after eating. They get very tired. Exercise makes their belly pain worse. So that's one thing to watch out for. If you have them exercise and they say that their pain is in the epigastric region is getting worse, think of MALS. It gets worse with standing, but it gets better with lying on the side. And this is the picture I wanted to show you. This is the normal picture. This is the celiac plexus, celiac artery, and this is the median arcuate from the diaphragm. In MALS, this artery is compressed. And along with it, there are nerves on this artery called the celiac plexus that gets compressed. So when they eat, it really gets very painful. The treatment is surgical decompression. Muscle pain, Epsom. So magnesium is a very good treatment for muscle pain. Epsom salt bath, 2 large cups of Epsom salt in a bathtub and soak yourself. You can use topical magnesium. If possible, in very severe muscle pain conditions, you can use IV magnesium. But if they're having muscle spasms or cramps, then they can try this drug called Cenemet. It's sold as Cenemet here. It's carbidopa plus levodopa. It's an old drug that is approved for treatment of Parkinson's, but half a tablet will be enough to help these patients for their muscle spasms. But these are generally a good treatments for. So oral magnesium doesn't get absorbed well. That's the problem. Menstrual periods are horrible for people with EDS because all their ligaments get loose, their mast cell gets worse, their POTS gets worse. So I always advise them to talk to their OB/GYN about stopping their menstrual periods. So if you have a patient that's really not making much progress, and every time they have a period, things go downhill, this would be the advice I would say, talk to your OB/GYN about the possibility of holding their menstrual periods. Cannabis, I actually checked last night. Apparently it is decriminalized in Israel. So it's an awesome drug for EDS. Apparently, I've noticed opioids don't work too well. I mean, they do work in some of the patients, but most of them don't really see a good response to opioids. But they do see a good response to cannabis. And it does not affect mast cell activation syndrome. Opioids affect mast cell and the GI system, but cannabis does not. The trick is that you must have an equal amount of CBD and THC in it. And I would avoid hemp CBD, but cannabis CBD plus THC, equal amounts, or maybe a little more CBD works better. Low dose naltrexone is another drug that we have been looking at for some time. This helps with fatigue and pain. The normal starting dose is 4.5 milligrams. You can talk about it to your patients to see if their physician will write about it. In fact, I gave a talk on low dose naltrexone in Israel 2 years ago. Exercising. This is exercising is really.
I wanted to know if the naltrexone has any side effects that.
Yes, it does. It has very temporary side effects. It's headaches, colorful dreams, or insomnia. And these are very, very temporary. They'll go away after some time. So I always tell patients to start in the morning. And so they don't have a problem. And but only they can take it in the morning or they can take it at night. It's up to them. But it's important that take it only once a day.
What should I?
So
If they decided not to continue, do they have to gradually stop or can they just stop right away?
they can stop it suddenly. Say, supposing they're taking LD and low dose naltrexone and they have to go to the hospital for an emergency surgery or something, they can stop it right away. It doesn't have to be tapered down. They can start it suddenly, they can stop it suddenly. No problem. Exercising in EDS. So remember, the tissue is soft and weaker. So they tend to have micro trauma very easily, and the tissue takes much longer to heal. So always exercise below their limit. Don't push them. Keep it under their limit of tolerance. If you push them too much, then they start to have more trauma, which delays healing. So won't be able to exercise for the next few days. So even if they're feeling good today and they feel like they can do much more, hold it. Tell them like, no, don't exercise more. Just stay under your limit. So you can. It is better to exercise every day than do a lot one day and then not exercise for 2 weeks. In this case, we are looking to strengthening their muscles, but there's only so much you can strengthen their muscles because the muscle tissue is not that strong to start with. Proprioceptive exercises are really nice, like juggling, balance board, wobble board, stork standing, which is standing on one leg, sitting on an exercise ball, slacklining, standing up on a pedal board. These are proprioceptive exercises. They're also good exercises for core strengthening, but these are also good for their proprioception. Aquatherapy is amazing. They can, because when you're in the water, you're 1/10 your weight. So there's no pressure on the joints. So your muscles can move better. Plus, they also have good proprioception because the pressure of the water, they feel that and it feels much better. So walking in water, running in water is good, but freestyle swimming, I don't recommend because they overstretch their shoulder joints, they overstretch their neck muscle joints, but they can do a breaststroke. That is fine, as long as they're not overstretching their joints. Other things that you can try are Feldenkrais. I don't get to see that much here. There are not too many practitioners. And like I said, supine exercise for POTS, that's another way to go. But remember that policy of no pain, no gain doesn't apply here. It applies to non-EDS, but not to EDSers. Start really, really slow and go slow. So if they can do 10 reps of bicep curls, so stay at 10. After maybe a few weeks, go to 11. That's how slow they have to go. Service dogs are amazing. I always recommend service dogs in patients with severe EDS, with their POTS, with their pain. It helps them. These dogs can detect dizziness or seizures before they happen. In EDS, they protect their limb from falling. If these people are in wheelchairs, they'll pull the wheelchair, they'll press elevator buttons. They can detect their POTS getting worse. So service dogs are exceptionally valuable. There is a book that got published a couple of years ago called Disjointed. It's written by a lot of EDS specialists, and I think it's an incredible book. You can look at it. You can recommend your patients to read it. It's written in very straight English, so most patients should be able to understand it. This is a quick one I wanted to bring up, lipedema and EDS. So oftentimes you'll see patients, most EDSers are very thin, but then you'll also see some EDS patients that are not as thin, they tend to be big. And they tend to have what is called lipedema, which is they have fat tissue collecting or lipid tissue collecting between their connective tissue. And it usually involves the buttocks, thighs, and calves. So you can see that it's mostly in the buttocks, calves, and thighs. That's where a lot of it is. You can actually feels different. Does not feel like regular fat. It feels more rubbery. But what we've noticed is there's not much literature, but what we've noticed is that there's a lot of correlation between hypermobility and lipedema in these patients. In some cases, these are two websites that you can look at. The problem with lipedema is because it's not fat, you cannot reduce it by exercise or dieting or even weight loss surgery. There's a very specific type of surgery that these patients have to go through to reduce that. It may also be associated with lymphedema at the same time. There is a condition called Dercum's disease. These are patients who have they have lipid tissue around them, but they have also got nodules within the subcutaneous tissue. See these nodules? And these nodules are extremely painful. And this is called Dercum's disease, often seen with joint hypermobility. I just put it in there because you may see that and you might think that, well, you've got joint hypermobility, you need to lose weight to take the pressure of the joints, but it's not that easy. They might have lipedema that might not be that easy for them to lose weight. And with that, we end our presentation. Thank you so much. Any questions?
Pradeep, I want to thank you so much. We are immensely grateful to you.
Could I ask
You're welcome.
And we have one
You're
more.
one question? Back to the orthotics. We were talking about shoe inserts. I don't know if that's also orthotics or if that's a separate thing. Because you said that if it doesn't feel good at first, it's probably not right for you. And I know that with orthotics, a lot of times it doesn't feel very good in the beginning for the patient. It takes them a while to get used to it. Is that the wrong way of thinking about it?
Right. So I used to recommend it to everybody who came with flat feet. I used to say, you need orthotics. And I had mixed results. Some people came back and they said, no, they didn't like them at all, no matter what. And some liked them. So I don't know how to decide whether who should use a shoe insert or not. So what I tell them is don't buy custom made because those are expensive. Buy something cheap, try it, and it might be very helpful. And if it is not, you can try. Sometimes you have to break into it. You're right. Sometimes you have to use it for some time to get used to it. But if they have been wearing it and they just it's making their pain worse, then it's better not to use it. And I think the reason is that some shoe manufacturers put an arch in the shoe itself. So if you put a shoe insert, then that makes the arch even higher and they don't like that. I'm not sure. There's a lot we don't know about these patients, but we're learning a lot. And so I just shared what I know from my experience.
Thank you so much.
All right, guys. Take care. Thank you so much.
If we have any more questions, would I be able to email you?
Yes, the email is right there on this page.
Okay, I really appreciate it. Thank you.
Guys, take care. All the best.
Take care. Bye-bye.